Good morning to everyone. Today's topic is red and white lesions of the oral cavity, part 1. The color of the oral mucosa depends on the concentration and dilation of the blood vessels in the underlying connective tissue, degree of the keratinization, amount of the melanin pigment in the epithelium, and thickness of the epithelium. Why the lesion appears white? Due to hyperkeratosis, acanthosis, which is thickening of the stratum spinosum, intracellular and extracellular accumulation of the fluid in the epithelium, which is called as a leukoedema, necrosis of the oral epithelium caused by microbes, especially fungi, which produces a whitish pseudomembranous layer, and reduced vascularity in the underlying lamina propria. Why the lesion appears red, which is due to atrophy of the epithelium, reduction in the number of the epithelial cells, and increased vascularization, blood vessels enlargement, presence of the blood in the tissue, increased hemoconcentration. You can see the diagrammatic representation of hyperkeratosis in the figure 1 and acanthosis in the figure 2, and there is the intracellular and extracellular accumulation of the fluid in the epithelium in the figure 3, and fourth one represents the microbes attached in the oral epithelium, which is particularly fungi. Other red lesions are due to atrophy of the epithelium and reduction in the number of the epithelial cells. There are many classifications. According to Burkitt, under infectious disease, oral candidiasis and oral hairy leukoplakia. Under oral potentially malignant disorders, oral leukoplakia, proliferative verrucous leukoplakia, erythroplakia, oral submucous fibrosis. Under allergic reactions, oral lichenoid contract reactions, reactions to the dentrifies and chlorhexidine. Under immunopathologic disease, oral lichen planus, drug-induced lichenoid reaction, lichenoid reaction of graft versus host disease, lupus erythematosus. Under toxic reactions, reactions to the smokeless tobacco, smoker's palate. Under reactions to the mechanical trauma, morsicatio and frictional hyperkeratosis. And other red and white lesions includes benign migratory glossitis, leukoedema, white spongy nevus, and hairy. Under infectious disease, mainly candidiasis, which is an opportunistic infection affecting the oral cavity, which is mainly caused by yeast called Candida albicans. The predisposing factors mainly convert the Candida from the normal commensal flora, which is in the saprophytic stage in the oral cavity, to a pathogenic stage called parasitic stage. The predisposing factors for the candidiasis are mainly local or general. Under local, denture wearing, smoking, atopic constitution, inhalation of steroids, topical steroids, hyperkeratosis, imbalance of the oral microflora, quality and quantity of the saliva. Under general, immunosuppressive disease, impaired health status, immunosuppressive drugs, chemotherapy, endocrine disorders, and hemantic deficiency. Candida species is mainly responsible for the candidal infection, especially are Candida albicans and Candida. Classification of the oral candidiasis. We have primary and secondary oral candidiasis. Under primary, acute pseudomembranous candidiasis, erythematous acute candidiasis, under chronic pseudomembranous candidiasis and erythematous candidiasis, plaque-like candidiasis, nodular candidiasis. Under secondary oral candidiasis, which includes familial chronic mucocutaneous candidiasis, diffuse chronic mucocutaneous candidiasis, candidiasis endocrinopathy syndrome, familial mucocutaneous candidiasis, severe combined immunodeficiency, Dijon syndrome, chronic granulomatous disease, acquired immune deficiency syndrome. What are the other candida associated lesions are denture stomatitis, angular cheilitis, and median rhomboid glossitis. What is pseudomembranous candidiasis? Acute form is recognized as a classic candida infection, affects the patients with antibiotics, immunosuppressants, drugs, or a disease. Oral lesions are soft, white, slightly elevated plaques occurring on the buccal mucosa, tongue, palate, gingiva, and on the floor of the mouth, which is curdy white plaques, can be wiped away with the gauze and leaves an inflamed and sometimes bleeding area. The clinical representation of acute and chronic are mostly indistinguishable. Chronic form is associated with HIV infection and with steroid inhalers. And erythematous candidiasis, which is previously referred as a atrophic candidiasis or antibiotic sore mouth or antibiotic stomatitis, occur as a sequelae to the course of broad spectrum antibiotics, inhalational steroids, smoking, and diseases. Lesion appear as red or erythematous, may occur at any site, only variety of a candidiasis which is consistently painful. This is the diagrammatic and clinical representation of erythematous candidiasis caused by a inhalational steroid. Under chronic plague type or nodular candidiasis, chronic plague type replaces the candidal leukoplakia, which is characterized as white plaque, which is firm and white persistent plaques usually on the lips mostly, tongue and cheeks. The chronic plague type and nodular candidiasis have been associated with malignant transformation. The right one represents a nodular candidiasis and the left one represents the chronic plaque type candidiasis. Other lesions are denture stomatitis. It is mostly prevalent in the palatal mucosa. It is classified into three types. Type 1 localized to minor erythematous sites. Type 2 affected majority of the part of the denture covering the mucosa. Type 3 has a granular layer. The angular keratitis is characterized as erythema and fissuring, scaling, and the saliva is tend to pooling in, keeping the area mostly moist and favoring for the yeast infection in the oral cavity and involving the perioral skin. Creates a clinical pattern called chelocandidiasis. Median rhomboid glossitis, which is a atypical or paramedial rhomboid glossitis. There will be central papillary atrophy, posterior lingual atrophy, posterior midline atrophic candidiasis. Okay, which is characterized by erythematous lesion in the center and posterior part of the dorsum of the tongue. Lesion has mostly oval configuration resulting from the atrophy of the filiform papilla and lobulated. Smokers, tensiovirus and patients using inhalational steroids have an increased risk, which is asymptomatic. Management is restricted to a reduction in predisposing factors. Kissing lesion, which typically refers to a lesion that occurs on the hard palate, which is due to the direct result of contact lesion on the tongue. Mostly it is associated with median rhomboid glossitis. What is secondary oral candidiasis? It is accompanied by the systemic mucocutaneous candidiasis and other immunodeficiency disorders. It will be chronic mucocutaneous candidiasis. It also affect on the skin, nail bed, genital mucosa. Sometimes face and scalp may also be involved. Occur as a part of endocrine disorders such as hyperparathyroidism and Addison disease, myeloperoxidase deficiency. It is also caused by Chirac-Higashi syndrome, severe combined immunodeficiency syndrome characterized by a defect in the function of the cell-mediated immunity. Thymoma also causes the secondary oral candidiasis, which is a neoplasm of the thymic epithelial cells. Chronic familial mucocutaneous candidiasis, an inherited disorder which occurs at the early What are the oral candidiasis that are associated with HIV? 90% of the AIDS patients have oral candidiasis. The most common types are pseudomembranous candidiasis, erythematous candidiasis, angular cheilitis, chronic hyperplastic candidiasis. Coming to the diagnosis and laboratory findings of candidiasis. The Candida laboratory investigation is mainly smear, swab, imprint culture, impression culture, salivary culture, as well as the oral rinse. In smear, there will be scraping and smearing directly into the slide, which is simple and quick. The main disadvantage is it has a low sensitivity. In swab, it is taken by rubbing cotton tipped swabs over the lesional tissue, which is relatively more simple, but the disadvantage is selecting sampling sites is very critical. Coming to the imprint culture, where the sterile plastic foam pads dipped into the suboid broth is placed on the lesion for 60 seconds and the plate is placed on the agar plate and colony counter is used, which is very sensitive and reliable, can discriminate between infected and the carrier sites also. The main disadvantage is the reading above 50 CFU per centimeter cube square can be inaccurate. Selection of the sites is very difficult if no clinical signs is present. The fourth one is impression culture by maxillary and mandibular alginate impressions, casting in agar fortified with broth is used under incubation. Useful in determining the relative distribution of the yeast on oral surfaces, but the disadvantage is useful as mostly in the research tool. The fifth one is salivary culture, where patients will export 2 ml of saliva into the sterile container vibration. Culture on the SAB agar was done by spiral plating counting. The advantages are as useful as imprint culture, where relative distribution of the yeast on the oral surfaces will be identified. The main disadvantage is considerable chair side time and not useful in the xerostomia patients, cannot identify the site of the infection. And the final one is oral rinse, subject rinse for 60 seconds with phosphate buffered saline, which has a pH of 7.2 0.1 and returns to the original container concentrated by centrifugation, cultured and counted as in previous methods. It is comparably insensitive with imprint method, better results in CFU less than chronic CFU less than 50 centimeter square, a simple method. Disadvantages recommended for surveillance cultures in the absence of focal lesions, cannot identify the site of the lesion. Coming to the management of both oral and the systemic candidiasis. First, we have to identify the systemic or underlying local causes. If in case of AIDS or diabetes patient, no rectification is possible. If the rectification is possible, physician opinion must be sought. The patient given as topical route, parenteral route or oral route of drug administration. For topical, we have to give on denture stomatitis, angular cheilitis patients, median rhomboidocytis. For oral route, pseudomembranous hyperplastic candidiasis, acute atopic candidiasis can be recommended. In topical, what are the drugs are given are clotrimazole 1% cream 5 times per day for 2 weeks, clotrimazole 2% gel 5 times per day for 2 weeks, clotrimazole 1% solution 5 times per day for 2 weeks, nystatin 5 lakhs unit tablet 4 times per day for 14 days, crushed and mixed with water, used as a mouth rinse and swallow. And the other drugs are Hamizin 2 lakhs per unit per ml, which is given in 2 to 3 times per day as mouth rinse for 7 to 10 days. Fluconazole disposable tablets with water to use as a mouth rinse for 3 times per day for 14 days. Most commonly used is clotrimazole cream. The other parental route of drug administration is amphotericin B IV infusion 0.53 mg per kg can be infused over 4 to 8 hours. Okay. Then oral route fluconazole 150 mg twice a day for 14 days can be given. Fluconazole 200 mg twice a day for 14 days can be given. Ketoconazole 200 mg once a day for 1 to 4 weeks can be given. Itraconazole 100 mg once a day for 14 days can be given. This is a clinical representation of a case where 84-year patient reported with the denture stomatitis. We have advised for topical candid mouth paint for 2 weeks, advised not to wear denture and prescribed chlorhexidine mouthwash. The left one is preoperative photographs and the right one is postoperative photograph. As you can see, the denture stomatitis particularly on the denture bearing area. The patient advised correct antifungal treatment and the patient lesion was rectified. Other infectious white lesions are oral hairy leukoplakia. Oral hairy leukoplakia is a corrugated white lesion that usually occurs on the lateral or ventral surface of the tongue in patients with severe immunodeficiency. It is most common in HIV associated lesion and it is second most common. Marker of the disease activity associated with low CD4 T lymphocyte counts. It also occurs in the immunosuppressive drugs, those who are taking immunosuppressive drugs and in cancer chemotherapy are also associated with hairy leukoplakia. It also occurs those who are in prolonged steroid therapy. What are the clinical findings? Most commonly involves a lateral border of the tongue but may be extend to the ventral or dorsal surface. Occasionally located on the buccal mucosa, typically clinically appear as a wide vertical fold which is oriented as a palisaded pattern. Lesion on the tongue are corrugated and have a shaggy or frayed appearance. It may also display as white and somewhat elevated as a plaque which cannot be scraped off. It is often a bilateral and asymptomatic lesion. Diagnosis only based on the clinical characteristics or histopathological examination, and it is also caused by Epstein-Barr virus. Histopathology is mainly characterized by severe hyperkeratosis with irregular surfaces, acanthosis with superficial edema, corrugation, and often thin tufts hairs can be seen from the ventral surface, and numerous polycytic cells, virally affected cells, balloon cells in the spinous layer, pycnotic nuclei and homogeneous viral nuclear inclusion with residual rim of normal chromatin is seen. Candidal hyphae surrounded by polymorphonuclear granulocytes of common feature. Epstein-Barr virus can be detected by in situ hybridization or by immunohistochemistry. What are the differential diagnoses for oral hairy leukoplakia, especially hyperplastic candidiasis, idiopathic leukoplakia, leukoplakia induced by tongue chewing, tobacco-associated leukoplakia, lichen planus, lupus erythematosus, white spongineous, verrucous leukoplakia. The treatment part indicates no treatment. Condition disappears when the antiviral medications given for the HIV infection such as ridovidin and acyclovir or ganciclovir is used. Topical application of podophyllin resin 25% solution or tretinoin, which is retinol, is for short-term resolution of the lesion. Hairy leukoplakia is not related to the increased risk of malignant transformation. Thank you. These are the references.